do anybody have any questions to Mr. Hassan? Okay.
Okay,
Yes.
thank you so very much for
Thank you so
having me
much.
here.
Yes. Thank you so much, Mr. Hassan. Have a nice day. Yeah. Now we have the next presenter, Dr. Alina Lavinia, Antoaneta, Oancea, from Davila University, excuse me, of Medicine and Pharmacy, Bucharest, from Romania. She's going to give us a wonderful talk about the title Tumors with Atypical Location.
Thank
Yes.
you very much for the presentation.
Yes. Thank you. You shall go ahead, Alina.
Yes. Okay. So I will discuss about tumor with atypical location, especially more exactly in the larynx. Why atypical location? Just a moment. Why I want to discuss about this pathology? Because this atypical pathology present unique challenges by the small patient population, because the diagnosis is difficult and delayed due to a lack of medical and scientific knowledge. Also because of the poor understanding of the natural history of the disease and its progression without intervention. There are no previous paths to follow, and the clinical goals and therapeutic solutions are often unclear and non-specific. So today I will present three more special cases that I have faced lately. I will start with the giant beloved externalized Zenker's diverticulum. In 1769, Ludo described a discovery he made following an autopsy. He described an abnormal dilatation of the posterior wall of the hypopharynx. Between 1877 and 1878, Zenker described the physiopathological mechanism and classified them into thrust and traction diverticula. Wheeler published the first treatment that apparently was actually described by Zenker, but he didn't publish it. In 1958, Harrison added to the surgical treatment the subdiverticular myotomy. Zenker diverticulum was a pharyngoesophageal junction diverticulum, appear predominant in men in 7-8 decades. Occur in an area of poor resistance located at the pharyngoesophageal junction between the oblique fiber of the inferior constrictor muscles and the transverse fiber of the cricopharyngeal muscles. The new perspective in the pathophysiology of the development of this pouch are represented by the aging process, the most important being fibrosis and dysfunction of the cricopharyngeal muscle, compromising the elasticity of the upper esophageal sphincter, its opening, and creating and increasing pressure in the hypopharynx. There is a relationship between GERD and Zenker diverticulum. Among the causes are esophageal motility disorder, structural lesions, stricture, loss of muscle elasticity of the cricopharyngeal muscles. Initially, patients complain about foreign body sensation, dysphagia, regurgitation, aspiration pneumonia, unexpected weight loss, the pathognomonic sign, which is cervical borborismus, bitonal voice, hypersalivation. There are 5 stages described by Negus, from the first stage when we can see mucosal protrusion to the 5-1 with retroclavicular development in the mediastin. For the diagnosis, we need an X-ray with barium transit series, which will show the retentive character, upper digestive endoscopy, esophageal manometry, pH metry for 25 hours. Untreated, Diverticula can lead to ulceration and perforation of a diverticular sac, upper gastrointestinal bleeding, aspiration pneumonia, diverticulis infection, and also esophageal carcinoma. The treatment of choice is surgical. Also for diverticula smaller than 2 centimeters, we can try to wait with periodic follow-up of the patient, but in rest, the surgical is the treatment of choice. Over time, many types of surgical approach have been developed. We can approach an endoscope technique or an open one, or combination between rigid transoral endoscopy and open cricopharyngeal myotomy. Postoperatively, we can have some complication immediate, like hematoma, damage to the recurrent laryngeal nerve, pharyngocutaneous fistula, or mediastinitis, and also tardive complication, lack of improvement in symptoms, and recurrence of dysphagia. So let's start with the case presentation. A 76-year-old woman was brought to the emergency room by ambulance from her home at 3 o'clock in the morning, accusing the appearance of succiform formation externalized at the level of the mouth, surpassing the oral commissure by approximately 7 centimeters. The patient denies any symptoms preceding the appearance of the tumor. She is extremely anxious. She just wanted me to cut the piece of meat and go home. This is the image of the patient. Upon careful ENT examination, it is observed that this tumor was bilobed. At fibroscopy, we notice that the tumor seems to have a possible origin at the level of the esophageal mouth. We ask for a neck and chest CT, and that shows on the right side wall of the esophagus, immediately above the upper thoracic opening, an esophageal diverticulum with an hour bundle of approximately 0.5 centimeter, with its intracavitary prolapse at the level of the esophagus, pharynx, and oral cavity. The patient was informed about the therapeutic option, the benefit and the risk of the surgery, and she agreed by signing the informed consent, and the surgical intervention was performed. We started with rigid esophagoscopy to identify the point of origin of the diverticulum, and then continue with right presternocleidomastoidean cervicotomy and diverticulectomy. With the endoscope inserted up to the point of origin of the diverticulum at 15 centimeters from the upper dental arch, we fix the endoscope in this position, and the right cervicotomy is performed, followed by lateral esophagotomy with traction and inversion of the diverticulum, and diverticulectomy at the level of the implantation, preceding by subdiverticular myotomy of the cricopharyngeal muscles. The diverticulum, you can see here, it's approximately 20 centimeters, was sent for the histopathological exam, which confirmed the diagnosis. The evolution was favorable. The barium transit confirmed the sealing of the sutural 7-day postoperatory. At the flexible laryngoscopy, we didn't find pharyngeal hematoma or edema. I wanted to present this case not only because it is a woman, but I didn't find another case like this, a rare case of giant bilobed diverticulum externalized at the level of the oral cavity following prolonged coughing effort. Also, it is important the need for emergency treatment given the potential for life-threatening, because it could break or swallow it and enter in the larynx. That's why it was kept on his cheek until the surgery. Surgical treatment is the choice, preventing complications that can endanger the patient's life and improving its quality. The choice of both the therapeutic method and the surgical technique is very important and directly related to the stage of the diverticulum. This should be communicated to the patient during the pre-therapeutic discussion. The next case is a laryngeal Kaposi sarcoma. It's an angioproliferative disorder described for the first time by the Hungarian dermatologist Kaposi in 1872. Initially was considered an AIDS-related illness. After the discovery of human herpes virus 8 in 1994, it was found that all cases were related to this virus in immunocompromised patients. From an epidemiological point of view, it is classified in classic, endemic, acquired, and epidemic Kaposi sarcoma. There are 3 stages, from the spot stage with macular lesion to plaque lesion, and in the nodule stage, we have tumor formation. Are frequently located in the skin with extension to the oral mucosa, gastrointestinal tract, and lungs. If the extension is to the lymphatic nodes, it will produce obstruction and after that lymphedema. I want to insist in this rare location in the larynx and in the eyes because you will see it in our patient. I found less than 30 documented cases of laryngeal Kaposi sarcoma, mostly the epidemic form of Kaposi sarcoma. The tumoral Kaposi sarcoma was positive for LANA1 in HIV-8 genome. For the positive diagnostic, we need, it is necessary the biopsy. Imaging investigation are very helpful. The treatment is individualized, from local therapy to radiotherapy with small doses, chemotherapy, immunotherapy, and highly active anti-retroactive therapy for the AIDS-related type. I want to mention that it's not a treatment to complete remission because the lesion reappear, especially in the treated areas. So I will present the case of a 67-year-old man for whom an ENT consultation was requested from the radiotherapy department. He was undergoing radiotherapy for Kaposi sarcoma in the upper limbs. The patient was diagnosed in April 2017 when a tumor of the left lower eyelid was biopsied. The histopathological exam confirmed by immunohistochemistry exam established the diagnostic of Kaposi sarcoma nodular stage. Then several hospitalizations follow for the removal of newly appearance lesion with biopsy reconfirmation. As I said, at the time when I examined this patient, he was hospitalized in the radiotherapy department and complain about dysphagia and odinophagia. The fibroscopy show a vegetative violaceous round oval tumor with irregular edges located at the level of the epiglottis on the right side, about 1 centimeter. You can see it here. And in the narrowband imaging view, we see a very rich vascularized tumor mass. Another lesion you can see on the anterior chest, on the conjunctiva, on the leg. Those are already cauterized. The patient was tested for a HIV, B and C hepatitis in our clinic and was negative. The case was analyzed in the oncological committee and the surgery was chosen. An endoscopic method was used to perform the subtotal epiglotectomy using the tooth approach. Under general anesthesia with orotracheal intubation, the laryngeal retractor was mounted, and to create space, the anterior retractor was placed at the base of the tongue, and the pharyngolaryngel transoral approach was practiced. Under endoscopic control, with the help of the Thunderbit instrument, subtotal epiglotectomy with integrated hemostasis control is performed. This transoral ultrasound surgery was introduced in 2014 by Fernandez as an alternative to the much more expensive transoral robotic surgery system, classical technique, or laser devices. It is a minimal invasive technique aimed at treating benign or malignant tumor of the oral cavity, pharynx, and supraglottic larynx. It involves the use of a special retractor, a series of orthostatic blades, a complete endoscopic system, forceps, and this instrument, Thunderbit, which is a device for cutting, coagulation, and sealing. Now you can see some intraoperative findings with this Thunderbit instrument. The histopathological exam was conclusive for Kaposi sarcoma, and evolution was very good with no abnormal morphopathologically elements. Why I want to present this case? Because it is a rare case of Kaposi sarcoma in the larynx. We know the rare tumor of the larynx account for 2-3% of laryngeal tumor. But this was not necessarily a surprise for us. We already know that the patient have Kaposi sarcoma. Using the narrowband imaging as an endoscopic biopsy showed us a very high vascularized tumor, which strengthened the suspicion of Kaposi sarcoma. But please remember, the NBI cannot replace the histopathological examination. The use of the tooth endoscopic approach with the Thunderbit instrument contributed to a shorter hospital stay. The patient didn't require tracheotomy, didn't require a nasogastric tube, and was fed orally from the first postoperative day. When determining the therapeutic plan, we must take into account the complexity of the disease, the effectiveness and side effects of the treatment, the life expectancy, don't forget that it's incurable, and the quality of life. And the last one is a secondary non-Hodgkin lymphoma. This group of diseases are biologically and histologically very heterogeneous group of neoplasm originating in the lymphoid system, can affect lymphatic nodes, any organs, and contain lymphatic tissue. Here is the classification. Clinically can mimic any condition. For the diagnostic, we need a node or organ biopsy performed surgically. Also mandatory is the bone marrow biopsy. We need imaging examination. Here is the staging. The evolution is very heterogeneous. It can be indolent or aggressive and very aggressive. It's common in young people, rapidly progressive clinical course with diagnostic in early stage and significantly curable, but it's significantly curable. The complication consists on compression phenomena and organ infiltration. The treatment is adapted according to histological type and risk factor. And the case, it was a lady of 72 years old who came to the hospital in February 2022 with acute respiratory failure and pharyngolaryngeal tumor formation. Actually, it was one of my patients, which I saw in November 2019, when she came with an XCT showing a multiple lateral cervical and submandibular lymphatic nodes bilateral and in the upper mediastinum. The INTI clinical examination confirmed the presence of these nodes. So in December, I performed right lateral cervical tumor biopsy with the result of non-Hodgkin lymphoma. She followed 6 courses of chemotherapy every 21 days. And in June 2020, the CT of the body showed no suggestive lesions for secondary determination. But 1.5 years after that, she came, as I told you, with respiratory insufficiency and the fibroscopy. I show this supraglottic endolaryngeal tumor obstructing more than 2/3 of the laryngeal crown. The neck and chest CT scan show a left paramedian pharyngolaryngeal tumor formation and also juxtacentimetric left jugular-carotid adenopathies. No secondary pulmonary findings. So I perform a tracheotomy and after that, direct suspending laryngoscopy or biopsy. The result was again non-Hodgkin lymphoma. The patient followed again 6 courses of chemotherapy every 21 days between March and June. And you can see in April 2022, the fibroscopies show no superimposed morphopathological elements. In April, we can decannulate the patient, and in July, the CT show no secondary determination. Why I want you to discuss about this? Because currently there are no characteristic clinical findings that distinguish laryngeal lymphoma from other laryngeal neoplasms. Instead, I thought that there is second cancer. Extremely rare case of secondary localization of non-Hodgkin lymphoma in the larynx. It's very important, but it's very extremely rare. So this led to the suspicion of another type of cancer. And also, it was very rare, the rapid evolution of the symptoms, which brought the patient to the doctor when she was already in acute respiratory failure. I want to share these cases to ensure conditions for the correct and early diagnosis of these diseases, to improve the quality of life of these patients, and to give them the hope of life lived with dignity. Thank you very much.